avant d'être construit. Le problème, c'est que dans un cas, tu vas tu vas pas voir. Non. Je réponds pas à la question. On m'a demandé au rabbin, le rabbin va se prononcer sur la liste des articles d'identité et d'enveloppe. Et un rabbin peut dire éventuellement en conclusion ou en introduction, même si c'est à la base de l'identité, mais il y a plus de liste d'identité. On ne peut pas se contenter de Ah non, on va se voir. Parce que la clé, c'est de savoir que pas obligatoire.
Okay, great. Thank you so much, Diego, for organizing this panel and bringing us all together. This is a panel on rethinking global governance for health. I'm Jennifer Ruger from Yale University, and we have Judy Russ from Doctors Without Borders and MSF, and we also have Andrew Wong from the Council of Foreign Relations, and also from Seton Hall University. What we're going to do is we have 3 presentations today. I'll start first and give a general overview of a framework that I've been working on in global health governance. And then Judy will talk about access to medicines and a framework for putting patients' needs first. And then Andrew will be talking about China's role in global health governance. And then we should have time for questions after the panel. Hopefully we'll be able to get through all our presentations. And if you wouldn't mind holding off till the very end for your questions, we'd appreciate it. Thank you. So this is a panel about rethinking global health governance. And so I think I was asked to start because I've been trying to think about this for a while, and I'm going to be presenting on an article that I actually published recently in the Journal of Epidemiology and Community Health called Global Health Governance as Shared Health Governance. So my presentation is based on this article in which I'm putting forth an alternative framework or model for global health governance. I'm going to focus my remarks on a few different areas. The first is just giving an overview of the key aspects or components of this model called shared health governance. The second is talking a bit about current problems in global health governance in the practice, policy, and theory, what I've characterized as the rational actor model of global health governance. And then I'll talk a little bit about what's needed and in terms of a focus on common goals and common commitments around a social agreement model and contrast that with a political bargaining model. And then talk about the object of a social agreement, and that is a moral conception affirmed on moral grounds. And then finally end with mechanisms for shared health governance through shared global health sovereignty and a global health constitution. Okay, so first just to say that despite a lot of very strong successes in global health in which I don't have time to go through all the different successes. The current regime of global health governance can be understood, or so I argue, as one of transnational and national actors pursuing their own interests, so-called rational actor model. And that this particular model, rational actor model, provides insufficient justification for an obligation to assist in meeting the health needs of others, and rather an ethical commitment to providing all with the ability to be healthy is required. And that's where the moral conception comes from. An alternative model of shared health governance can help provide a roadmap or focal points and help with the glue that brings different actors together to better effectuate cooperation in health around several key ideas. One is public moral norms as shared authoritative standards, ethical commitments, shared goals and role allocation, shared sovereignty and constitutional commitments, legitimacy and accountability, and then country-level attention to international health relations. And a framework of social agreement is posited against or contrasted with a political bargaining model that's based more on self-interest. And then a global health constitution can help in delineating duties and responsibilities of different actors and then help hold actors responsible for these different roles and responsibilities. And working together through this framework of shared health government is based on shared ethical commitments. Let me say, just before going on to the current problems in global health governance, that the shared health governance framework builds on a theory of global health justice that I've been working on called provincial globalism. And in that theoretical framework, I do develop a moral conception for global health justice, but I don't have time to go into that in great detail today. But in general, just quickly, provincial globalism rests on a general duty to reduce shortfall inequalities in central health capabilities, and then stipulate shared global and national responsibility for that. Responsibility allocation rests on specific roles and functions, and also on voluntary commitments, and also on internalizing public moral norms that then create this shared authoritative standard. Okay, so that's just the general overview. In terms of the current problems in global health governance, and they do occur at the practical, the policy, and also the theoretical level. You all heard about the escalation in different donors and actors in global health. There's been an unprecedented level. This hyper-pluralism and fragmentation is being characterized as anarchic, as requiring coordination and control. It's been described as chaotic, as congested, as complex, as different private and public actors pursue different goals and objectives that don't necessarily align with or link with the goals and objectives of country governments. Sometimes there are conflicts in donor priorities, and that those requirements that donors put on countries then create an overwhelming environment sometimes for recipient countries, and these different systems and procedures and different standards of implementation can make coordination extremely difficult. The other aspects of this rational actor model can be described as different actors, whether they be NGOs, ministries of health, different multilateral organizations, individuals, public-private partnerships, these different actors, that these actors take their own sets of goals and objectives and take actions based on analysis of the costs and benefits of their different options. And it's important to recognize also that even civil society and NGOs that have a very popular flavor to them have their own interests as well. And so they fall within the scope of this effort to think about what the different interests are and the perspectives are in these calculations. Just a couple of empirical examples. It's been estimated that half of health aid in sub-Saharan Africa fails to reach intended clinics and hospitals, that the confusing priorities and policies in areas like immunization and vaccine delivery and overlap are problematic and have caused great difficulty for countries as a result. In the paper, I identify several areas of self-interest maximization. I don't have time to go through all of them. Some of them are things like donor ideology and preference, inter-NGO competition, profits, geopolitical and strategic interests, etc. So these are some of the things that are going on with respect to the rational actor behavior. And there's no dominant theory, or there's no theory that has come forward to really try to elucidate the current global health governance and understand principles upon which a new approach might develop. So that's where the SHG comes in. I also talk a little bit in the paper about other different frameworks, right to health, human rights, public goods approaches, other theories of international relations that I don't have time to go into now. So the diagnosis is that global health governance has failed to develop and effectuate a moral norm of equity in health, that a theory of global health justice is required to bind actors together in cooperation for health in the absence of this theory. And that cooperation based on self-interest alone, in contrast to a shared cooperation, does not recognize the provision, for example, of public goods that require collective exercise and action among all around specific goals. So let me move now to common goals and common commitments and the contrast between social agreement and political bargaining. So in terms of what's needed for common goals and common commitments, I'm stipulating that we need a genuine consensus. So we do have goals, we have the Millennium Development Goals, we have lots of agreements, we have lots of different ways in which we've said we're going to meet certain objectives. But we need a genuine consensus, a normative model of social agreement, as compared to what Rawls calls a modus vivendi. That's the result more of political bargaining around interests and tit for tat or reciprocity. So what's the difference between a social agreement model and a political bargaining model? Well, a political bargaining model is based on some sort of short-term or temporary assessment of tit for tat or making agreements based on narrow self-interest. However, the social agreement model is based on an overlapping consensus that is a moral conception itself and is affirmed on moral grounds. So the role of values and ideas and norms has an important role to play in this type of a social agreement model, and more so than in terms of a political bargaining model. I don't have a lot of time to go through that contrast today, but there's more in the paper. And that global health requires a set of principal ideas to shift the focus from material and power interest of a political bargaining model to moral concerns and a moral conception. And this is necessary to solve collective action problems, and that this moral conception can create focal points and can help for coalitions around different goals. So then the moral conception I put forward is this provincial globalism idea. The last thing, and then I need to end, the last thing I want to focus on is mechanisms then for shared global health sovereignty around the idea of a moral conception of global health equity. Again, I don't have time to go over the provincial globalism work in detail, but the the global health environment is one in which we don't have a world government for global health. We have global health institutions, we have a number of multilateral and bilateral actors, but we don't have a world government. So in the absence of a world government, with global authority and enforcement powers to ensure the compliance with goals and agreements, we need something else to try to internalize compliance around these shared conceptions. And I'm proposing a global health constitution as a way of trying to effectuate this and coordinate independent yet interdependent actors. It is not the WHO Constitution. The Global Health Constitution arches above the WHO Constitution. It does not replace it. It complements it. And it sets forth a framework of procedures and authoritative standards and principles for respective roles and obligations for global health actors. I suggest that there's been drawing on the work that's been done in global justice around duty dumping. I suggest that there's been a great deal of duty dumping in the global health world in terms of expectations of different actors that have not been laid out and already articulated and agreed to and internalized. And so this type of a framework, a global health constitution, would actually lay out the obligations. The obligations would be clear, and evading them would actually no longer be an option. So the Constitution it's not a legal constitution. It sets out a meta-level system of regulation through self and others, through ethical commitments, and the WHO's role in it is within that Constitution. So I need to finish up, but let me just conclude by saying that that we can work magic with the computer. Through this type of a higher order charter, and we can talk more in the discussion period if there are more questions about it, and through public moral norms around a moral conception of global health that has been missing, compliance and enforcement and accountability of actors who are discharged with their global health duties is more possible, both at the global level, but primarily at the country level. And I don't have time to go into work that we've been doing in our research group around accountability and legitimacy at the local level around these ideas, in particular work that we've done in Malawi. But I'm going to end there so that we can get to our other speakers and let Judith take over now. Thanks.
Thank you so much. It's a great introduction. I do think to share a lot. I'm coming from a different perspective. I'm coming from a very pragmatical treatment provider perspective. MSF, Doctors Without Borders, we basically provide treatment in developing countries. But I do share a lot of what you said, and I do think my presentation, hopefully, will be in a very similar line, and will specifically focus on one proposal that's currently under discussion, hopefully very soon at this World Health Organization in May, of a possible way to deal with at least a little piece of it, of global health governance on research and development. So first of all, thank you so much for inviting me. Thank you so much, Diego, for organizing and treating us so well. It's a pleasure to be here. As I said, I'm speaking on behalf of Doctors Without Borders, Médecins Sans Frontières. We are an international humanitarian organization. We don't really know a lot about theory of global health governance. We basically deal with it on a day-to-day, but we don't have a lot of academic theory perspective. So I'm going to talk from that perspective, the pragmatical perspective of working on the field, and my colleagues basically sharing with us their frustrations, the good news and the bad news that they see every day, and how this has been affected by the global health governance, and how the global health governance needs to change to respond to the needs of our doctors and our patients and our staff in the field. So, as I said, medical humanitarian organization. Sometimes humanitarian seems to be contradicting with development, but I do think MSF is also working on development. We do humanitarian and we do development, and just to give you an example, we do humanization, we do human rights, we work on neglected diseases. I do think humanitarian and development. Maybe academics could give you a much more detailed correlation of both concepts, but that's something that we internally are discussing very, very often, the relationship between a humanitarian or medical organization and its effects on development. And I'm here representing a subsection within MSF. It's called the Access Campaign. We were created in 1999. We're basically an advocacy think tank policy mini group within big MSF. And we basically were created in 1999 as a source of three main concerns that our field and our teams in the field had. First, medicines are unavailable, meaning that they don't exist because there's no incentives to develop them. So I'm talking mostly about neglected diseases, but I'm also talking about, for example, pediatrics HIV/AIDS medicines. I'm talking about vaccines that don't need a refrigeration system. I'm talking about products that are not adapted to resource-poor settings. So that's the first concern of our fields and our medical teams, and they ask us, how is it possible that the current world doesn't respond to the needs that we have in the resource-poor settings where we work? Try to figure that out. The second main issue, so first, they are unavailable. The second, they are unaffordable, meaning that they are too expensive for our patients and for the governments and the civil society with who we work. So many patients are currently still in need of access to affordable medicines. Medicines are highly expensive. How can we learn from experiences where medicines have been reduced in price? HIV/AIDS is a great example, no? 99% price reduction of the last 10 years. Right now, more than 6.6 million people are receiving access to HIV/AIDS medicines thanks to the availability of affordable generic medicines. How can we learn from this experience, improve access to HIV/AIDS medicines, but also translate that experience into other diseases that are riding, and just to mention non-communicable diseases, cancer medicines are highly unavailable because they are unaffordable in many developing countries. And then the third issue was unsuited, meaning that they are not, they don't exist or they are not adapted to resource poor settings where we work. So the three U's that we call, unaffordable, unavailable, unsuited. This is basically our mandate, and this is why I'm going to talk about. So coming from a very pragmatical and very focused perspective. After more than 10 years, the Access Campaign basically has reached a point that we basically think the current innovation model is broken, that we need a new framework that not make us choose between innovation and access, but that allow us to fulfill both goals. That we need a new global framework that gives us fair, sustainable systems that promotes both innovation and access to medical technologies. And I'm going to present how this framework basically is broken, and I'm going to present two ideas on how this framework could be a new framework could be explored. So for us, one of the keys of the problem, there are many causes of the problem. There is not one single cause, but one of the key problems is the way research and development is funded and is incentivized. There is a problem on the fact that we are basically linking the way we do research and development, and we pay for research and development, and the way we pay for the final products. We basically are promoting a system that recovers research and development costs with high prices. So we are creating incentives that are exactly in the wrong, that go exactly in the wrong direction. Basically, the current incentives are thinking about a profitable market. Therefore, if you're a patient suffering from neglected diseases, you're out of the picture. You don't have, there is nobody incentivized to do research and development for you. But also profitable market in the sense that you can recover these R&D costs with high prices, with basically excluding competition. Therefore, the HIV/AIDS model of doing technology transfer and having access to generic medicines is not available or is under threat for other diseases or even for newer products on HIV/AIDS. Because if you don't have the capacity to pay high prices, you're not an interested customer, you're not an interesting patient for the current system. So we want to break that link. We think the principle of the linking, of separation of the cost of research and development from the price of the final products is the key, is one of the key solutions to go forward. This seems very esoteric, very maybe very theoretic, but it is very practical. We see this every day. So just to make it real to you, we have a huge problem in the field. We don't have a point-of-care diagnostic for TB that is adapted to the countries where we work. It doesn't exist. We do have, there's an interesting pipeline on tuberculosis that's growing. There are better diagnostic tools, but we don't really have what we need. We need a point-of-care diagnostic tool to diagnose in the rural communities where we work, to diagnose children, that works for children, and that works for HIV/AIDS TB co-infected patients, because that's what we've seen in the field. We see HIV and TB co-infection, we see a lot of TB in children, and we need a point-of-care affordable product. And this doesn't exist. Why it doesn't exist? Because there's no money going into research and development on TV, or there is not enough money. If you look at the budget, Obama proposal for this year, 2013 budget proposal, there is a cut proposed for TV. TV is not really sexy. It's not really something that it is increasing in fund. There is no incentives to invest in TV. There is no money, but also there is no coordination. There is no correlation about what every different actors are doing. There is research and development going on TV, but there is no coordination of what the different actors are doing. There is no prioritization of the needs driven by the field needs. It's more driven by sometimes academic institutions or theories of science, but we don't see a public health overview that focuses on the needs that we have in the field. And third, when we have some advance in TB, like for example, very recently, there's a new diagnostic test that's been launched in the market, and we're starting to pilot in some of our projects, specifically in Africa, that's called Gene Expert. It's a very promising tool. It's really fantastic to start better diagnosing TB, and this is going to have a huge effect on MDR TB, multi-drug resistant TB, that's highly untreated right now in developing countries. But what's the problem with this diagnostic? It's a computer-based, it needs a plug, it needs electricity, it's a huge computer, and then it's super expensive. We're talking about more than $10,000 for machine. So the issues of affordability, the issues of the resource where we work, basically where there's no electricity, or basically there is no thinking in the design of the products, affordability and needs-driven resource poor setting innovation is not part of the equation. So this is just an example of a failure of the market, of the failure of the current innovation system, that it's not giving what our patients need. They need affordable point-of-care diagnostic for TB. And I could give you many other examples of things that we need and that our patients need, and they don't exist. So we think, basically, there are new global norms, new mechanisms that think about the way innovation is financed, is coordinated, and is incentivized are needed. And the good news is this has been discussed for more than 10, 20 years. I mean, there's been a long process of discussions. This is known. I mean, the current innovation system doesn't work. The good news is that after basically 4 years of negotiations with the World Health Organization, we are maybe moving to a point where the World Health Organization is going to start discussing some of these ideas. So it's difficult to say when it really started, but I will say I really think that 2003 was a very important year. That's when a commission of the World Health Organization was created on public health, intellectual property, and innovation. It was a member state request to the WHO to create an independent commission to look at the relationship between intellectual property, innovation, and public health, and see what has worked and what has failed. And that commission basically is a CPIH report concluded in 2006 that the current innovation system has failed, but because it's mostly driven by the capacity to charge high prices, by the mechanisms that rely on intellectual property and monopolies. And therefore, if you're talking about developing country markets, that doesn't work. So that was for us, a huge landmark. What happens after that? There was an intergovernmental working group that was created, also driven and highly driven by member states, that concluded in 2008 with a global strategy and a plan of action. The global strategy and the plan of action on global health, intellectual property, innovation and intellectual property is a mandatory reading, I will say. The CPH report is a mandatory reading for any student that's interested in global health. It is really a very important document that highlights a possible pathway on how these issues could be solved. And it talks about a lot of different strategies and a lot of different mechanisms. And I don't really have time to give you an overview of all the different elements. I'm going to highlight one of the elements. It identifies the need to look at incentive mechanisms and to link, separate the cost of innovation from the price of the product. So it basically goes into very similar direction than the direction that we have come to the same conclusion. So we go in very similar directions. And it had an element that it was unresolved. And the element was we need new incentive mechanisms. It talked about the possibility of a research and development convention or treaty. That was basically the unsolved part of that negotiation, and there was an expert working group that was created to look at these issues. And I'm a little bit embarrassed to talk about the expert working group because we have the chair in the room, Professor John Norway, who is basically the main author and the chair of that expert working group. So he should be here explaining the deliberations and the conclusions of the expert working group, but I'm going to do the best I can to see how I see the report. I think this report that was released last week, it's also mandatory reading We don't agree with everything that the report said. It's, of course, it's an expert working group, and it's not written by us, civil society, so it's not exactly, we have some disagreements on some of the aspects. For example, on the scope of the report. The report focuses, has a mandate, the expert working group had a mandate to look at developing country diseases. We do think that, for example, non-communicable diseases are a growing burden in developing countries, and we will have liked the report to also cover stronger issues of non-communicable diseases. Some of the analysis of the innovation mechanisms are not exactly in our direction. We are maybe a little bit more radical in some of the issues some of the ways we look at these issues. But overall, the report is a fantastic report, and it does a very good job of defining and explaining the problems, the way we know the problems are, of assessing the different proposals that are there, and basically evaluating what are the pros and cons from a public health perspective. And at the end, their main conclusion, and I'm just going to read you the sentence, because I do think this sentence is going to be landmine. Right? It's really going to change the way, hopefully, the way we think about global health. It says, on balance, we consider that the time has come for member states to begin a process leading to the negotiation of a binding agreement on R&D relevant to the health needs of developing countries. And we do agree, it is time to rethink the global norms on research and development, and to do it in a way that's binding, that has enforcement, and that puts global health as a priority. So the report does a very good case on explaining why binding, why we need to have strong norms, not soft norms, and what are the possible main elements of such a convention. It basically talks about financing, sustainable financing for research and development. It's very concrete on the proposals that it stands as, and the proposals that it evaluates, and the ones it recommends. It is very concrete on the need for better coordination and needs-driven research and development, and it's very concrete on the issue of incentives. It highlights the importance of the principle of the linkage, of basically putting access at the upfront and from the beginning, when you start thinking about the way you do innovation, when you're thinking about developing countries where there is no capacity to pay high prices. And basically, the report, as I said, was launched, was released last week. It's at the WHO website. It's a 225, I think, page report, highly recommended, mandatory reading, I would say, for any student of global health. It's going to be discussed at the next World Health Assembly. There are different ways this could move forward, but basically the idea is to start a government-driven process to look at the possible elements of such an international convention, and hopefully this will advance, and we will have in the near future better global norms on research and development. But my point is that independently what happens at the World Health Organization, and independently if there is political will or not to advance on global norms on research and development at the multilateral level, we know what's the problem. We know that some of these, what are the possible mechanisms that could help in finding a solution. So some of these proposals, some of these issues should start to be taken in consideration at the national and the regional level, independently of what happens to the World Health Organization. When here, with the United States government is looking at incentive mechanisms for research and development for developing countries, like priority review vouchers, advanced market commitments, or many others, most of these mechanisms are flawed in its design. They have important flaws. They are not needs-driven. They don't talk about affordability. They really don't think, they don't take in consideration what we know needs to be taken in consideration. So independently, if we manage to get a global norm, global binding norm on these issues, we should start applying some of our learnings to regional and national policies and decisions on these issues, both here at the United States, and the effects that you can imagine, the effects that United States has on research and development for new technologies is huge, but also at the countries where we work. And we are advocating basically with member states to do that, to focus both in the international level and change the norms at the international level, but also start applying some of these lessons and some of these experiences at the national and regional level. So, as I said, there's many other issues on global health governance, and MSF doesn't have an opinion on everything. We're very pragmatic, and the campaign specifically is very pragmatic. We're dealing with the three mandates that I mentioned to you. Medicine should be affordable, available, and adapted to the resource-poor settings where we work. But there are many other issues that worry us. The WHO reform process, we're very concerned with some of the trends. The reform of the Global Fund, and some of the push for a more public-private partnership model for some of these global institutions that are should be setting norms and should be technical, neutral, no conflict of interest, free of conflict of interest institutions. So there's many other issues we could discuss today, and I hope there is discussions about many other issues. We don't have opinions about everything. I can relate you how global health governance is affecting the field and how some of these discussions have a direct effect on many, many millions of lives. But I wanted just to share with you one specific example of one possible promising, I'm done. So one promising proposal that we are endorsing and that we are very confident that has the right elements for a possible solution. Thank you.
Well, thank you. Actually, if Jennifer presents a sort of more theoretical approach, and Judith presents a more practical approach, I'm probably more like a mixed approach, or half-baked approach, if you may. And I don't have a PowerPoint presentation. I like to use the excuse for this old-fashioned approach, that is power crops. PowerPoint crops, absolutely. So, well, today actually I'm going to talk about, actually thank Diego for assigning me that approach, because before I came here I was debating which topic should I work on and talk about, and then I found, well, this is exactly one of the topics I was thinking about. So it's about China and global health governance. Basically, we know that over the past 2 decades, there's changes in the political and epidemiological field that have dramatically changed the landscape of global health governance. Among those, one of the important changes is this proliferation of all kinds of global health actors, like beyond the state actors, we have intergovernmental bodies, we have the NGOs, charity foundations, the PPPs, the public-private partnerships, and but one of those changes we observe is this rise of the so-called emerging powers, right? Especially the BRICS countries, Brazil, Russia, India, China, and South Africa, which are actually injecting new resources, momentum, innovations into global health governance. And for the sake of time, I'm going to focus just on China. Basically, this presentation is going to be based on the paper I'm writing, which examines the impact of China's global health governance participation. And I want to address, actually focus on this question, that is, how has China's involvement had an impact on global health governance? So I'm going to look at China's effectiveness in promoting global health governance by focus on 3 areas. The first is the health-related foreign aid or development cooperation. The second is China's contribution to global disease prevention and control. And thirdly is on China's role in global health rules, norms, and standards making. So I'm going to talk about this one by one. So first, let's talk about China's role as an aid donor. We know that China is both a recipient and a provider of health-related foreign assistance. That is actually something new, because for a long time, China actually is a net donor of foreign aid. Beginning in the 1960s, actually, the level of actual foreign aid reached an all-time high in the 1970s, driven by the need to export revolution, expand China's political influence in the Third World. But for political domestic reasons, it refused foreign aid. In fact, during the 1976, the Tangshan earthquake, when Japan and other OECD countries offered aid to China, China just said, no, we don't want any foreign aid. And in the health field, during 1963 and 1982, we found that actually China's health aid basically was conducted through this dispatch of these medical teams, right? Actually, 6,500 Chinese health workers joined those medical teams and served a total of 70 million people in 42 countries, including 32 in Africa. But since the mid-1990s, we have seen actually some changes in China's health aid policies. in order to expand its political influence and boost pharmaceutical exports in Africa, for example, the government launched a broader charm offensive to construct healthcare facilities, including hospitals, anti-malaria centers, and donate medicines, especially medicine to Africa. Well, I know that this contribution of China's health-related development assistance, contribute to health system capacity building, like the third world, especially Africa. But this role should not be exaggerated. We know that China is still not considered an active donor to global health. In fact, it did not join officially the donor club until December 2011, last year, at the high-level forum on aid effectiveness in Busan, Korea. And until very recently, we know that it makes only a nominal contribution to the Global Fund, but in the meantime, it has been aggressively seeking Global Fund grants. So that draws criticisms from people like Jack Cho. And Chinese health aid does not always align with international practice. If you compare China's the health aid practice with those of the OECD countries, you find China's aid program does not attach political strings, or of course except for the issue of Taiwan, and it prefers bilateral aid. It focuses on constructing those infrastructures, facilities, healthcare facilities in the hospitals. Well, this is something that the United States was doing by the 60s, for example. We invested, for example, this JFK hospitals in Liberia, but that didn't work out. That probably is the only case that you have a facility named after JFK that didn't work. But when the United States is moving away from investing in this health facilities, China actually invested heavily on those. China also is focused on the so-called tide aid, while the OECD countries have moved away from tide aid. So far, the Chinese health aid was repackaged to promote the exports of its pharmaceuticals, for example. Actually, in Tanzania, to give you an example, the Chinese government bought this anti-malaria drug and medicine from this Chongqing. Chongqing is associated with all this big scandal in China. The Chongqing-based Harley Pharmaceuticals to make donations to local hospitals and clinics in Africa. And finally, China, there's a lack of participation of the civil society organizations in health aid, that only narrows the space of cooperation between China and other donors. So this is the problems of the concerns for China as an aid donor. Secondly, I want to talk about China's contribution to global disease control. China is now a leading supplier of drugs and drug ingredients in the world. And actually, believe it or not, 63% of the aspirin sold in the United States actually is produced in China. And certainly with the sheer size, the population, this is an important factor to reckon with in global disease prevention control. But if there is anything, event that taught China the importance of seriously, directly engaging on global health governance, it is the 2002-2003, the SARS crisis. Highlight that China is a weak link in global health governance, therefore generated momentum for China to strengthen its disease surveillance and surge response capacities. And these efforts, of course, contribute to the WHO's global outbreak alert and response network go on and strengthen its early warning and surveillance activities. And since then, we found China has demonstrated its ability to also orchestrate multilateral cooperation over international health at the regional, even sub-regional and global levels. It hosted those the International Pledging Conference on Avian and Human Influenza in January 2006. It hosted the International Conference on H1N1 pandemic in June 2009, and more recently, it organized the first meeting of health ministers from the BRICS countries in Beijing, actually last year. And this is what we call the China's new health diplomacy. But that new health diplomacy has its own constraints, of course. For example, in responding to international public health emergence such as the 2005 the H5N1 outbreak or the 2009 H1N1 pandemic, China's contribution is still sort of marred by this problem of cover-up, lack of transparency. We know that in the 2009 H1N1 pandemic, China probably violated the international health regulations, the IHR, by instituting this travel and trade restrictive measures not based on WHO recommendations or any legitimate public health justifications. And well, this overreaction and in the pursuit of short-term domestic political goals actually undercut the trust and goodwill among the states that doesn't help, global health governance, especially in terms of the international disease prevention and control. And there are also concerns of China's potentially misuse of its influence in global health governance, especially with regard to WHO, because China's engagement in global health governance is primarily through the World Health Organization. We know that they campaigned very hard to have a Hong Kong Chinese, Margaret Chan, to be the WHO Director General. And in January 2012, that is earlier this year, the Chan was nominated again by the WHO Executive Board to be the next WHO DG. And then for the first time in the WHO history since the 1960s, there was only one candidate for that position, one who's won the position unopposed. When I was actually doing the interview in Geneva, someone just told me, maybe just said speculation, that the fear of fighting an unwinnable war with China was the primary reason of the absence of more candidates for that job. And finally, I want to talk about China's role in shaping global health rules. China has shown willingness to work cooperatively with other players to set rules and norms of global health governance. It has, for example, shown flexibility in the revising of the international health regulations in 2005. That is considered one of the most radical changes to govern international cooperation over public health emergencies since the mid-19th century. And China's concern initially when it was negotiating the IHR, participating in the negotiation, it was concerned about the so-called universality principle because it worried that they might potentially justify Taiwan to be a member state of World Health Organization. It was very concerned and actually threatened that China would not allow that happen. But then it dropped its opposition to include the universal application when the chair of the draft committee substituted all people to all countries so that the new text reads, the implementation of these regulations shall be guided by the goal of their universal application for the protection of all people of the world from the international spread of disease. So if there's no state, this term there, well, China said, well, we're fine with that. So they have shown some flexibility. Also, China, we know that it attached utmost importance of social political stability, right? But it actually also showed flexibility in allowing the WHO to take into account the rumors, so-called sources of information provided by non-state actors in making decisions. In justifying that, the Chinese negotiator said, well, we'd rather have the WHO handle these rumors rather than have the CIA do that. Even with this progress, of course, China's approach towards shaping global health governance rules and norms remains narrow and limited. Unlike Brazil, which has shown leadership on the global health rulemaking over a wide range of issues, China was not an active participant in the negotiation of the FCTC, the Framework Convention on Tobacco Control. It was not an active participant in the universal access to HIV/AIDS medications, or the pharmaceutical intellectual property rights. And China's participation in global health governance is not always positive. During the negotiation of the FCTC, for example, China, along with Japan, Germany, and the United States, were the leading opponents of the key provisions to minimize the treaty's effectiveness. Also, when this FCTC treaty was in place, China was a signatory nation, but by January 2011, last year, right, we haven't found any significant progress China's made in complying with the treaty. In fact, China was believed to be the least effective in complying with the FCTC. And that is to prohibit workplace smoking. This is just a brief discussion of China's engagement in global health governance. What I want to try to argue here is that when people examine China's engagement in global health governance, some people say, well, that some scholars believe that China is fundamentally state-centered, reactive, material interest-driven approach. Not only leads to a fairly narrow and limited engagement in global health governance, but this approach may also be unsustainable in the long run because it is increasingly out of sync with the standards for responsible behavior globally. But a close examination of China's participation in global health governance seems to suggest that seems to defy this pessimistic logic. China's participation is indeed making a difference in global health governance processes and outcomes. Through its health-related foreign aid, it contributes to the health system capacity building in the developing world. Its rise as an exporter of pharmaceutical products also promises to be a game changer in access to medicines and vaccines. And equally important, as its engagement becomes more substantial, it has shown strong interest and flexibility in global health agenda setting and rulemaking. Or to be sure, China's engagement in global health governance is still considered narrow, limited, we may say inelastic, not always constructive. That was evidenced in the handling of the H1N1 outbreak in 2009. And during the 2009, the H1N1 outbreak, basically we noticed that actually this gap or discrepancy. On the one hand, the government seems to realize the importance of international cooperation in dealing with a major disease challenge such as the H1N1 pandemic. But in the meantime, when it was actually handling the outbreak, its approach is still sort of driven by this realpolitik, right? That what you may call a realist approach. But this discrepancy between the neoliberal penchant of international cooperation and this realist-driven state response is not unique to China. We know that even this country, right, during the outbreak, the HHS secretary will suggest that the United States would not donate the vaccine to poor countries until 150 million at-risk Americans have been inoculated against the virus. So that is completely also a realist approach in the IR literature. Similarly, actually perhaps equally important, these constraints and limits are not static as the domestic and international context for China's engagement is changing. in view of this growing international pressure for shouldering more global responsibilities, there are indeed nationalist scholars, officials, they view these demands and pressures as part of like international conspiracy of slowing down China's growth. But we do find this more pragmatic officials who feel strongly the need to expand Chinese participation in global health governance. When I was having lunch meetings, okay, 1 minute, with these officials in charge of this international health ministry, and they said we do feel the pressures. And they actually recently, when I was doing interviews in Geneva, I was told that they actually designing a new global health strategy, but basically they plagiarized the Switzerland's model, the approach of global health governance, and they are going to have and also they borrowed the U.S. approach toward making a specialized agency on foreign aid like the USAID. So as China becomes more receptive to international norms, pressures, and influence, it is anticipated to play a much bigger role in global health governance. Thank you.
We started a little late, so we still have...
We still have about 20 minutes.
Okay, still have about 20 minutes for questions, comments. Yes, if you could say your name and maybe
Sure.
affiliation too. Yeah.
I'm Bill Nelson. I'm one of the mid-career program people here at the Kennedy School. I have a question both Dr. Ruger and Ms. Bruce, if I got your name right.
It's okay.
You both, in essence, have made a good argument that the global governance system is broke, it needs to be changed, it should be more morals-based, but that ultimately people or government should be accountable. And so you posit this new constitution. My question is, still, how do you enforce it? Are we really going to be any further ahead if all the heads of government go to the UN and sign a document? How does it actually become enforceable?
Want to go first?
Yeah, of course, that's the issue, no? So this specific proposal, and again, the chair of the expert work will be sitting next to you, so maybe he could respond better than I do. The specific proposal looks at Article 19 of the WHO Constitution and takes as a precedent the Tobacco Control Convention. Yes, so far I would say that the stronger precedent the WHO has as a tool, as a binding norm setting. The agency WHO could be as strong in setting norms as WTO. We don't have a WTO similar dispute settlement mechanism, of course. That's something that helps to have a dispute settlement mechanism to enforce the only global norm that currently exists, basically the TRIPS agreement. So if you have an international globalization of intellectual property norms and you have the WTO settlement mechanism, you will have more luck in enforcing intellectual property norms. Or if you have ACTA, the Anti-Counterfeiting Trade Agreement that's currently under discussion, and that contains, and you have USTR as an enforcement mechanism, threatening trade sanctions if governments don't raise the level of intellectual property protection, you have more luck. But if WHO and ministers of health and global health-driven stakeholders are serious about it, there is a possibility. In Article 19 of the WHO Constitution, allows for WHO to have a role in norm setting and a binding norm settings. It depends on do we really want norms that are enforceable and binding on global health. That's yeah. I don't know if I respond to your question.
Yeah. Can I do it? Yeah. Okay. So I think that the current system won't necessarily be revised to be more enforcement-oriented. I think we've had a number of years in which we've had attempts to make the WHO stronger, and even sort of soft powers like travel advisories can, they can work pretty well. We saw in, for example, the case of SARS. So, so the accountability and internalization at the country level and the new mechanisms to institutionalize. So the Global Health Constitution that I'm talking about is based on an idea that there's a consensus across different actors at the national and the international level. So the agreement to be held accountable is imbued in that institution. And then at the country level, the mechanisms for holding governments accountable are the political mechanisms in their own countries. However, I think that the work we did, for example, we did some work in country in Malawi and looking at accountability for the National AIDS Plan there, and trying to look at whether or not both horizontally the non-state and state actors were buying into and agreeing and had consensus around the strategy, and also who was doing what in terms of the implementation of the strategy, but also vertically, international organizations that were coming in and were involved in that, UN or non-UN based, and the national government. And was there buy-in and was there agreement and consensus of who did what? And we basically tried to evaluate by asking people's perceptions of whether or not that process was fair, reasonable, whether accountability mechanisms were in place, whether the resources were sufficient to implement the AIDS strategy, and for vulnerable groups, those who are affected by the decisions included in the process of decision making. These types of indicators of trying to understand whether or not around it, and that's a particular disease, we can hold accountable multiple actors at once. I think that's the issue. It's not just one country or one group of actors, or it's not just the global system or the national system. What we now have in global health governance is multiple actors working on different problems and at the same time. And so mutual accountability is very difficult to institutionalize. So that's the type of system that possibly could work a little better than what we already have.
Thanks.
Hi, sorry, last time we queued up, so I thought I'd come stand up here. My name's Alexis, I work at Harvard Law School, and I'm also a student at the Graduate School of Education here at Harvard. So I wanted to get into design and implementation a little bit, because I think there's a lot of potential for negative impact, which you guys have not talked about. I'm thinking specifically of the colonial era vaccination programs and the amplifications of HIV. So I'm just curious to hear how you, from a governance perspective, are thinking about these issues and incorporating that into the design and implementation.
Can you say more about specific aspects of negative impact that you're thinking about?
Sure. In the case of HIV and AIDS, the amplification of the disease through well-intended colonial vaccination programs. What kinds of programs today do you see have the potential for both a positive impact? But I'm just curious to hear more about the perspective on the negative impact of people coming together. You have great potential for good, but you also have a lot of things, negative outcomes that could be impacted with so many people working together.
You guys want to take a crack?
Surely not everything that comes of people working together is great.
No, of course not. I mean, well, look at democracies. Some people think that, in some democracies, majority or plurality is, not so great. So, any type of just because it's a participatory environment and we agree to and think that the procedures are fair doesn't mean that we think that the outcomes, ultimately, from a consequential perspective, or if we look at an outcome and say, that doesn't sound right to me, or that doesn't seem like that would be the right outcome. So just by bringing people together doesn't mean that we might necessarily, for sure, or doesn't guarantee, let's put it that way, positive outcomes. However, if you look at it from a temporal perspective, and so there are processes in place to reevaluate both the mechanisms for bringing people together in terms of the decision-making process, and this is what I was just explaining in this little study that we did. We evaluated this process of participation in the National AIDS strategy. So you have processes for evaluating the process, but also processes for evaluating the outcome. And so, that's sort of a more temporal way to sort of incrementally think through what could go wrong or what does go wrong and try to understand it better. Now, we certainly have lots of examples in development. For example, I thought you were going to say structural adjustment programs, which is the poster child for what went wrong in development. But we also understand that the process by which those types of strategies were developed were ones that were inconsistent with the way that we're now thinking about the paradigm for development, which is much more of a country-owned. I think that's a cliche and it's a buzzword, but it's much more of a country-owned process than it was before. So. More questions? Why don't you go? Yeah.
Hi, my name is John Lee, and I just finished my MPH last year in Hong Kong, and I'm now training as an international development volunteer in a US volunteer organization. So I got two questions that might be related with each other. So one is several years ago, we had the Doha Declaration attached to the TRIPS, which allows countries to declare some kind of health emergencies to kind of circumvent the TRIPS agreement to import pharmaceuticals from other countries. So my question is, how did this declaration influence the access of essential medicine in developing countries so far in these few years? And the other one is, now we could see a very huge expansion of generic drugs industry in countries like Thailand, Brazil, India, and also China. So the other question is, what do you think is the future of this, the contribution for this generic drug industry to increase the access of essential medicine to other poor countries in like Africa and India, and what needs to be done or changed in the global system to tap these resources into the poor people who really need this medicine?
Thank you. Happy to look at that.
This is exactly the issues that we follow. I do think you raised two very important points. Just to clarify, I do not read Doha Declaration as really what word did you use? You use a word kind of contradicting the TRIPS agreement, or basically, for me, the Doha Declaration was a hugely important political and legal document that was agreed at the World Trade Organization in 2001 that basically reinstated what was within the TRIPS agreement is the right, basically, to have some balance on the way you implement and enforce intellectual property norms. So there was really nothing new in the Doha Declaration apart from it's a political document that says when you negotiate in the TRIPS agreement in 1995, you agree, and you reach that agreement, that you will basically globalize intellectual property norms, but there will be some flexibility when global health is affected, and that governments will have the right and the possibility of balancing public health and profit-driven behaviors. And the Doha Declaration basically was a political and a legal document that reinstated that. What has been the effect of the Doha Declaration? That's an excellent question. I do think it's been insufficient because we're still there. We still have a huge need of access to medicines. There are millions of people that don't have access to medicines. You could look at it from a positive perspective, that there has been a use of some TRIPS flexibilities, compulsory license and others, and we could talk about it in some developing countries, specifically mostly about HIV/AIDS has been, and specifically mostly in least developed countries. The use of TRIPS flexibilities in middle-income economies have been so far, until very recently, nearly non-existent. We have seen the first compulsory license ever last month in India for a cancer product. And we've seen before, like in the last 4 or 5 years, compulsory license in Thailand and in Brazil. So it's been quite, we have a few examples of the use of these flexibilities, but not enough, because there's many patients that still need use of access to medicines. The effect of the Doha Declaration in the North, meaning on putting a brake on the pressure that the United States and the European governments are putting on developing countries, nearly non-existent. They have not stopped. So we have the EU right now negotiating a trade agreement with India that are basically pushing the bar beyond what was agreed in 1995. We have the US government right now negotiating an Asia-Pacific regional agreement that has the worst intellectual property chapter we've seen in years. So the Doha Declaration has really not changed the way the Europeans and the US see developing countries, have not really put that balance that was in the TRIPS agreement in their mind yet. So that's why we think, apart from pushing, and the Doha Declaration basically was a push, the use of TRIPS flexibilities is a push, we need to just change the way we think about innovation. That's why we have a lot of hope on this process that I described to you, the WHO process, on rethinking innovation tools, because we have to do pushing, and we will continue to pushing publicly and privately, but we also have to rethink the way we do innovation. So when we rethink innovation and we talk about the principle that I highlighted, the issue of the linking, no? Separating the cost of R&D from the price of the product. The second question that you raised, the importance of manufacturers in the South, is key. Because the idea is basically that we don't need to recover R&D costs with the control of the manufacturer and distributor process. So we need affordable ways of manufacturing these products. And HIV/AIDS is a poster child for that. More than 80% of the products that we currently use in developing countries to treat HIV/AIDS come from India. But not only us. Global Fund, PEPFAR, US taxpayer money going to treat HIV/AIDS in developing countries, highly reliant on Indian generics. The power of the Chinese generics, when, to be completely honest with you, when the quality standards raise, is going to be very important. The power of manufacturing these products in Thailand, in Brazil, in Africa, is going to be extremely important. But we need to play the incentives the right way, to have economies of scale big enough so there is incentives for these companies to develop these medicines. We also need to play incentives the right way so there is still incentives to produce innovation. So that's what the conversations that we're very interested in having. And that's why we think this report that the expert working group put forward last week is a possible way of rethinking that. I hope that's useful.
Just to follow up, actually, what Judith just said. And actually, when that the TRIPS agreement, Doha, it had an impact on the emerging powers' capability and incentives of making generic drugs, but the impact actually is not the same. You know, we know that Brazil and India have more incentives and more capabilities in producing generic drugs, and actually that contributes significantly to global health, you know, by having the affordable drugs available, accessible to millions of people worldwide, you know, with HIV, dealing with HIV/AIDS. But China, for example, initially was very hesitant, you know, by using this mandatory licensing to produce generic drugs. But in part is the issue of incentives, in part also the lack of capacities, domestic capacities. Because now we seems to be seeing that there seems to be on the same page, and the last year in Beijing, you know, they issued this political declaration, you know, pledging they can work together, you know, the accessing of medicines, you know, transferring the technologies, you know, to the developing countries. Although, you know, there's an issue because in India, for example, they said, well, because, you know, most of these generic drug producers is just a private owner, we have some problems, you know, doing that. You know, so this is again with the domestic political economy could be a factor that complicates the process.
You mentioned the need to separate the costs of developing new drugs and vaccines, say, from the costs, the prices that are charged to users, so that those medicines and vaccines could be more widely available, which is certainly a worthy goal. If you make that separation, though, who does pay for R&D, realistically?
Sorry, could you say your name?
Lisa Coburn.
So who do you think pays right now for R&D? I'm sorry, going back to you. No, so who do you think is paying for research and development right now? Let's do a dialogue better.
No, I'm asking you.
Okay, so I do think right now there are two ways research and development is being paid. If you live in the United States, it's mostly being paid with high prices, and therefore a system that's quite broken for US patients. But I live in this country, so I'm from Spain, but I can't see how the system is broken here, but that's outside the scope of my talk. But if you live in developing countries, you basically are not paying for R&D because you're not getting any access to it. So you basically out of it unless you're like the 2-3% of the population living in a country that has basically the capacity to pay high prices, like South Africa, Brazil, and Brazil could be better. Could be you maybe the 15%, 20% of the population can afford it. South Africa pricing policies of pharmaceutical companies are highly targeted. We have data on that to the top percent of the population that can afford it. The other, they're just out of the R&D model. They are just not interested, so they're not even paying for it. So what we're saying is that we want to give access to 100% of the population who needs it. Therefore, we need to bring production costs down to the maximum we can, and that means producing them at a cheaper manufacturing process.
My question is not about production, but about
Who
R&D,
pays for
which
it?
can be very expensive.
Yeah, R&D is expensive. I mean,
So who pays for that?
so who's paying right now?
That's not my question.
But I'm telling
talking about your ideal world where this change has taken place and R&D
So, for
costs are
example,
not borne by.
point of care diagnostic. There is a proposal for a prize fund for point of care diagnostic. The way we see that we need innovation for a point of care diagnostic for tuberculosis, I mentioned to you, this is a need we have. Point of care diagnostic for tuberculosis, it doesn't exist and we need it. So R&D for this tool is needed and we will have to pay for it. So the idea is that there will be a combination of sources of funding. First, traditional grants, NIH funding, companies investing, and second, a prize fund, an idea that's basically that we will create a focus, a mechanism that will incentivate research and development on a tool that doesn't exist, that will pay for that technology, but that will not pay, basically who will not be paying for sure will be the patients because it will be affordable. Yeah.
We've seen, for example, actually, when I was doing the field work in India, I noticed that many of the firms actually that are in Bangalore actually you have this IND actually outsourced. They actually do the IND for generic drugs. And then because this national government is still a very important source for the IND, we notice that South Africa has invested in that. Recently, Russia has, under Putin, also invested. They said we're going to invest in the IND for pharmaceutical drugs, and China certainly is doing the same. So.
And then you're next, and then.
Hi, terrific panel. I'm Stephen Marks, Harvard School of Public Health. Essentially, what you've been presenting to us as a global model for public health is a sort of a theoretical framework that goes from the realist paradigm to a more constructivist paradigm, and you see the potential for the realization along that continuum going from TRIPS Plus, which is the real world we're living in, through TRIPS flexibilities, through application of Doha, through the Access Campaign, through the GSPA, and then moving on towards an ideal which would really be in the constructivist paradigm, I would assume, of a global health constitution. So falling somewhere in the middle of that is the result of the committee, and we're going to hear in a second from its chair, of the expert committee. I haven't read the report yet, but if it is seeking to introduce a binding legal norm based on Article 19, the potential of that could be enormous. Presumably it's building on the global strategy and plan of action, which has the advantage and disadvantage of being multi-stakeholder. So out of ignorance on what you've produced, is it an intergovernmental agreement exclusively and one that would only bind states and therefore lose the opportunity to continue the engagement of other actors in a multi-stakeholder framework, or is there a potential for reinforcing a multi-stakeholder framework that really gets at the heart of the problem in this case? Because the pharmaceuticals are not going to go along with an innovation program that is going to destroy one of their strategies for return on investment, and that has to be addressed, as does the voices of the non-governmental sector and the voices of the people suffering, as is through the exemplary campaign of MSF's Access campaign. So the question is really, will this continue to be a multi-stakeholder process as the global strategy and plan of action is, or will the proposed treaty be an interstate treaty like the Framework Convention on Tobacco Control, and through which you're going to have to develop innovative ways of engaging the other players? Thank you.
Can we go here and then, yeah, and then maybe take the three at the same time? Is that okay?
Oh, no, sure.
Because I want to make sure we get to the questions, and we only have, what, 2 more minutes? Yeah. Yeah, okay.
Okay, so thank you. My name is Cara Matthews. I work with the Boston Public Health Commission in infectious disease, and my question was responding to a lot of the dialogue we've been having around innovation and research. And I really just wanted to know what specific incentives have to be in place to shift research from focusing on and addressing diseases that affect 90% or 10% of the world's population. For example, we're giving a lot of investment to, 90% of our investment is in issues that affect 10% of our world's population. And it's obviously a disproportionate investment, and we have all of these neglected diseases. And we're talking about pharmaceutical role in private-public partnerships, but if we don't even have the research to develop, pharmaceutical treatments for 90% of the world's disease burden, what are we going to do to address that, and what specific incentives need to be put in place to shift that trend?
Thank you. So incentives, and then about the treaty, and then one more, and then we'll respond.
Yeah, actually, I had a question for you, moderator, Professor Rüdiger. What is the difference between your proposal and a similar proposal on the Framework Convention on Global Health? Of course, in technicalities, they are very different, but in reality, I would just ask. And I'm happy to answer any of the other questions regarding the group, but I can come back to doing that.
Could you just say about the treaty? I think there was a question about the outcomes of
so
the working group,
yeah,
right? Yes.
First, I should say the name. I'm Jon Arne Rethinking. I'm a mid-career student here at the Kennedy School, and I've been chairing this consultative expert working group. So, first, how to pay for R&D. I think you need to first explain who's paying today, and it can be explained in 3 different ways. Of course, most of R&D is paid for by drug companies, but that's the kind of primary payer. The secondary payer is the consumer, the person who needs it. But the third consumer in those countries that are actually paying high prices are some sort of a health system. And the health system can either be insurance companies, it could be kind of social insurance programs, or it can be tax-funded programs. So in the end, those who pay for R&D today is the public. And what we are proposing regarding the needs of developing countries is that the public should principally take that funding upfront instead of paying through prices. That's the delinkage mechanism. And we propose that all countries should contribute in a fair burden-sharing way. All countries should contribute 0.1% of GDP.
Sorry, could you just say specifically about the enforcement mechanism, which was one of the questions?
No, it was not a question.
People's failing to,
Is it an interstate agreement, or will the multi-stakeholder dimension of IGWIG and of the global strategy and plan of action be maintained in this binding legal standard?
I was the lead negotiator of Norway in the IGWIG process. That was formally an intergovernmental process between governments, but with the observation and involvement of civil society and other groups. What we are proposing is an agreement between governments, but with involvement from other stakeholders. Private sector, civil society, philanthropic groups. But definitely the agreement is international agreement.
Yeah, which gets back to your, question about then how does that get to the root of the problem? Exactly. Yeah. Okay. So why don't you talk to the incentives?
Okay.
And you too. Andrew as well.
Okay. It's all the 3 questions I think is very related. I will start with I forgot your name.
Stephen Marks.
Okay. Professor Martin's question. Well, basically here about this governance, we talk about multi-stakeholder governance, but we have stakeholders, but we don't have multi-stakeholder governance now. That's a problem. That's why Michael Chang has come up with this idea of having a World Health Forum trying to engage the non-stakeholders, but that the forum idea was defeated by the World Health Assembly. Well, thanks to the collective efforts of our NGOs, and this is a bad example of how NGOs work together actually could turn out to be very counterproductive. This idea of having a framework convention on global health governance, global health, it would be a good idea, but it's not very realistic, won't be feasible in the long run, in the short run, because if you talk about the having a treaty, how to basically change the WHO constitution, right? If it takes 10 years to expand the WHO's executive board from member 32 to 34, I expect it will take much longer, to have a treaty, because the formidable, the hurdle here is this member state-driven process, right? Everything, make a decision, you have to get the consensus of the member states. So I don't think it's very realistic, and also such a convention would be a treaty, we know. So by definition, non-state actors cannot join. Right? So we're in the same situation as we are now with the WHO Constitution, right? Which is already a framework convention on global health. And furthermore, much of this fragmentation in global health governance has to do with states and non-state actors deliberately not wanting to use international law. Right? So simply having another treaty doesn't affect and solve that problem. In addition, a framework convention is usually a treaty. It does not require state actors to do anything substantive. So, it's not sure. I'm not sure how you could get any greater coherence out of this approach. You actually raised this question about these NCDs, right? To receive 10% of funding, even though it affects 90%. Well, actually, it contributes 90% of the mortality. Sorry, that's not true. Not 90%, 70% of the mortality. Actually, I raised the same question that Judith was there, where to the president of global development of the Gates Foundation. I said, well, look at the global health strategies. Like, you have 30% of your global health money going to HIV/AIDS and TB, malaria, but only 1% goes to the anti-tobacco, these campaigns and efforts. Have you ever considered shifting your funding priorities? That when I asked the same question last year to the global health, the president of global health of the same foundation, I got the basically explicitly, categorically no. But this year, what they was indicating, well, we're considering changes, but that is not going to happen in a very short run. So the Gates Foundation is not interested. The U.S. government probably is also not interested. Actually, President Obama, in the last year, when he was making the speech there, even though we just had this special meeting on NCDs, he didn't even mention the issue of NCDs. Even though his wife Michelle Obama seems to be campaigning very hard on that. And the U.S. government officials simply say, we're still stick to that MDG goals, which is focused, of course, on the infectious disease, not much on. So if you have two Washingtons not interested, and if these two Washingtons contribute to a majority of the global health funding, you're not going to see any significant change.
A lot of issues to cover. Just going to focus on two issues because I think there's been so much of it. It's very interesting. I'm going to focus on the governmental and non-governmental driven. We prefer a process that's governmentally driven. We are a civil society and we think it's safer and it's more sustainable. And it's more, we just prefer a system that it's government-driven. The equity negotiation that you mentioned that conclude with the global strategy and the plan of action, I was following very closely as civil society. And I thought it was a very good process, and it was government-driven, where the voices of civil society and industry were heard. And the government, not all the voices, not mostly people who basically had access to internet and could submit proposals or could go to Geneva. So it has a lot of limitations. It's not perfect, but it was a better than other processes that we are involved, that are highly close and highly controversial. We do think if you want to change global norms, it has to be government-driven. And we've seen basically a trend to change the way global norms are being set and incorporate private actors in the, meaning foundations, private sector, or even NGOs, into the norm setting. And WHO is one of these processes. I mean, basically, there is a trend right now to trying to modify the way WHO takes decisions and put private actors in the decision-making driving seat, and we see a lot of dangers on that. We want to see a process where technical decisions are being taken by governments and where the voices of us, civil society, of companies, and of foundations are equally heard, and their concerns are incorporated. but we prefer that the process is driven by government. So that's the way we see it. And that's the way we would like to see these global norms being set. And on the issue of incentives that you raised, this is basically the keynote. We need a variety of incentive mechanisms. The way the economies divide incentive mechanisms between push and pull. Incentive mechanisms that push and incentive mechanisms that pull focus. And we want to see both. We want to see more public funding going to research and development for the diseases that matter. So that's why we are supportive of this idea of creating binding global norms that all member states, all WHO member states, depending on their GDP and their level of development and their capacity to pay, will contribute more to research and development, will put more money on the table, but also we want to see the way the money is spent to be spent differently. So we don't want, basically, the current incentive mechanisms is based, as I said, in a link, complete link between the capacity to pay high prices and the capacity to recover R&D costs. Therefore, this has a lot of negative consequences I mentioned. Drugs that are unaffordable, and R&D is going to basically blockbusters and drugs that are highlighted for a market that can pay high prices and for the needs that can create a market opportunity. We want to see the mechanism change so the focus goes more into where the needs are and more for patients that need these medicines, not so much that can pay or not can pay these medicines. That should not matter. If you cannot afford a $10,000 a year drug, it should not matter. And the research and development environment should be thinking about you as a patient. And then we should think how we make these medicines affordable and how we recover R&D costs in a different way. That's, we think, it's the key of this principle of the linkage mechanism that's incorporated as one of the key proposals in the convention. And independently of the convention, it should be the guiding principle in the design of incentive mechanisms in the US and in other countries. Considering the patient not as a consumer, but as a patient. That independently of their capacity to pay high prices, they deserve the technologies and innovations that save their lives and improve their quality of life. That's the principle.
Okay, we have time for one last comment?
It's really up
yeah.
to you guys because
Yeah.
this is eating into our lunch hour, but if none of you mind, then suppose we can stay
In
here a
answer
bit
to,
longer.
yeah. So actually, Andrew, you did a great job of already answering part of my question about, no, it's great, no, because I think basically you showed the limitations of that alternative approach. I mean, there's a lot to say, but let me try to say a few things very quickly. The global health constitution, the provincial globalism is based on a theory of justice and health. It comes out of a perspective that moral conception is necessary because if global health equity is a goal that we have reason to value and are interested in as an international and global community. Global health equity meaning equitable opportunities for health of every person on the planet. Then in the current global health governance environment, and one in which looks like it's going to continue to be multi-stakeholder and multi-actor, there are different functions and different responsibilities that are required to achieve global health equity. The first is at the state level. And the Global Health Constitution, the provincial globalism idea, respects the sovereignty of states and respects the fact that we've had a lot of empirical evidence on the fact that it's very hard to get countries to do what the international community wants it to do, whether or not people agree to things or not. I agree about the point about treaties. We have a lot of empirical and case study evidence about the limitations of treaties in terms of their effectiveness in terms of compliance. So the provincial globalism idea is that the internalization of the agreement towards the goal of health equity occurs at a moral level and has to be institutionalized into political institutions in countries and into the ethos and fabric of non-governmental organizations that frankly have a legal right to do whatever they want. So unless they're in a domestic framework in which there are regulations and laws that are governing their behavior. So the Global Health Constitution is trying to get to exactly what you're saying, is that it's a multi-stakeholder environment now. And by the way, individuals themselves are part of the answer to health equity and delivering health equity. So unless we try to micromanage every person on the planet, which we're not going to be able to do, we need to have and the process by which the goals of health equity and the agreement around them and the consensus around them, which I think we really need to have a genuine discussion about. Because what we do see in many of these agreements is that they have been based on much more of a realist and other, rational actor, other types, which the point is we need to recognize that that's an acceptable way of thinking about global health governance and the way that it's been theorized and implemented. And if we want to alter that and alter the framework, recognize what has to be at the root of an alternative framework, and I'm saying moral conception is really what is driving a theoretical basis of justice with self-determination and recognition of sovereignty as a very important and a preeminent ideal and value in international governance. So I agree with basically what you said. There's more that we can say about it and talk about it, but thank you for the question.
Thank you so much for your insights and for